Good morning, ladies and gentlemen. My name's Peter Connaught, and I'm delighted to be here this morning as President of the Australasian Faculty of Occupational and Environmental Medicine, and to introduce the Ferguson-Glass Oration. The Oration is named after Professor David Ferguson and Professor William Glass, and in the early years, both Professor Ferguson and Professor Glass attended their jointly named lectures and are duly acknowledged as the two founding fathers of academic occupational medicine in Australia and New Zealand. Many of you will know Professor Bill Glass, who presented here himself only a couple of years ago and was a leader in terms of research, education, and an enormous advocate for the broader application of occupational medicine strategies for the benefit of the community. The late Professor David Ferguson was one of the founders of the Australasian College of Occupational Medicine in 1982 and was president from 1985 to 1987. And interestingly, his MD research thesis in 1969 was titled Stress and Health in Telegraphy. So there was a very early interest in the impacts of health on employment, which fits in very well with the oration which will be delivered now by Dr. Bernhard, who I'm delighted to introduce, and I'm delighted that Bernhard has come from Dublin for this oration this morning. Bernhard's oration is titled Health and the Wellbeing of Doctors, which is a particularly important subject for all of us in the college today and moving forwards with our trainees and ourselves. Dr. Blánaid is the Dean of the Faculty of Occupational Medicine, and she has worked as a consultant occupational physician at the Beaumont Hospital for over 20 years. She has experience in providing occupational and medical advice to industry, including having worked with IBM in Ireland over a 10-year period. She's a former National Specialty Director in Occupational Medicine and former President of the Irish Society of Occupational Medicine. Her MD thesis from the Royal College of Surgeons in Ireland in 2016 related to the subjects she's going to present now on the national study of the wellbeing of hospital doctors in Ireland. Please join me in welcoming Dr. Blánaid.
Good morning, everybody, President, distinguished guests, and colleagues. It is a great honour to have been invited to deliver the Ferguson-Glass Oration at your 2018 RACP Congress. I'm thrilled to be back in this beautiful city when I first visited as a young 20-something with my backpack in February 1984. The word awesome has lost its power in the modern world, where it is used to describe pretty average sights. But I well remember my first view of the Sydney Opera House and the Harbour Bridge, which I then considered awesome. I'm happy to say they didn't disappoint this time either, especially when I saw them yesterday on the Manly Ferry in the sunshine. You well know the many achievements of the two men whose contributions to occupational medicine are celebrated annually by this eponymous lecture. Sadly, I didn't have the privilege of meeting Professor David Ferguson, nor have I yet properly met Professor William Glass, a fellow of our Irish faculty, though I've heard him speak in Dublin, where in 1996 he delivered our faculty's equivalent of this lecture, called the Smiley Lecture. Having yet again failed to meet Bill at ICO 2018 recently in Dublin, I do hope to make up for that sometime during my visit here this time. I'm humbled to be here before you, and particularly to follow a long line of illustrious forebears, several of whom have been my heroes in occupational medicine. Julie Gerberding and Carol Black come to mind. I hope that's appropriate in the context of the speaker just now. I hope that my account of my research into doctors' well-being will uphold the passion and professionalism espoused by all of the Ferguson-Glass orators in their time. And I also look forward to contributing later today to your session on mental health in doctors. I'm also particularly grateful to my colleague and friend, Dr. Peter Connaught, a fellow Dublin graduate, though at a different medical school than I attended. We were there more or less around the same time. I thank him for his friendship and for entrusting me with this very prestigious oration. And thank you to all who've been involved in my visit here, because the hospitality has been spectacular. So, I'm going to talk about the health and well-being of doctors, not in a very general way, but rather in a very specific way in relation to the work I've been doing over the last 5 or 6 years in Ireland. So, you might wonder, why are we talking about this now? What are we going to talk about? Who is involved? How we did the study? Sorry, I'm having a little bit of difficulty here as I get used to this. There we go. And so what? And I suppose the so what will follow at the panel discussion this afternoon. I'm really just going to go through pretty much the findings of the study. So the why now, I suppose, is that we have a particular crisis in Ireland in medicine. My own daughter, actually, I have 2 daughters in medicine and a son who's not. What does that say? One daughter is working in the NHS in London, and the other is back working in Ireland after working 2 years in Australia, your wonderful country, a year in Brisbane and a year in Perth, and returned home last July. And it's a very different setting working in Ireland, and all of our youngsters who came in waves to Australia, although it's getting a bit tighter now that you're producing more graduates of your own, they're all coming back with these stories of how much better it is here than in Ireland. So you must be getting something right, even though I imagine, working in Australia is not a panacea for mental well-being in doctors. So we're losing our medics, we're using our young doctors with the so-called brain drain. There's lots of increasing numbers of complaints to our regulator, the Medical Council. But I suppose what really prompted and was really the impetus to this, my interest in this study, was the death by suicide of a young doctor about 6 years ago. In fact, there were two suicide deaths, but in very close succession, one a young woman and one a young man, both medical SHOs working in our hospital system. And that prompted a national conversation in the lay media and in the medical media. And what was really interesting then was a number of senior doctors came out and spoke about their own experience of mental ill health. And that really helped us to lift the lid off this particular Pandora's box. What happened in our college was that the then president convened a meeting with various senior medics, and I was the representative from our faculty. And I'd always been interested in the issue of doctors' health because I was seeing a lot of doctors in my clinics in the hospital I work in. Also, I'm the daughter of a hospital anaesthetist, and as I've said, I have 2 young daughters in medicine. So we had a conversation, and somebody said, but we've no research in Ireland, so I put up my hand. I said, I'll lead this. And it seemed just right at the time, in the autumn of my career, with my family now well grown. And occupational medicine, of course, is particularly family friendly. More recently, there have been further deaths, and only a few weeks ago, a young doctor died by suicide who'd worked in our hospital up until a few months earlier. But it was very interesting. The hospital where he worked when he died about 6 weeks ago had a much better capacity to deal with the situation, and everybody working there said, oh gosh, the hospital has dealt with this so much better than the last time. But the big question, of course, is why did it happen at all? It's great to be able to congratulate a hospital for managing the fallout, but what about doing something that would prevent it from happening in the first place? So this is your dark, rotten secret from the Sydney. In fact, Peter, I think you sent me this maybe a year or so ago from your own media. So I know you're far from immune here, even though I think you do a lot of things better than we do. We know very well the links between work and health. The evidence is as powerful as any of the evidence that you non-occupational physicians use in your daily practice. And yet somehow we don't seem to use this information when we're really planning for manpower and so on. Manpower? We know that work with excessive demand, as the previous speaker has already mentioned, when coupled with low support and low levels of control, has a negative impact on health. And we know that a negative psychosocial environment in work is associated with depression and common mental disorders. So the evidence is compelling and goes back several decades. I think of all of the things that I read in my fairly vast reading when I was doing this work, was from Michael West, who's the head of thought leadership in the King's Fund in London. And I leave you to read that piece for yourselves. That really we are creating patients for our own system if we don't start to pay more attention to this issue. And of course, it's not just doctors, it's all of the other health professionals, and indeed the other health workers who work in a system that can be very highly demanding and at times very dysfunctional. So at the start of the project, I thought the first thing we needed to do was to identify the sources of stress for our hospital doctors. And I was focusing unapologetically on the hospital doctors because that was my cohort. I look after all the other hospital workers too, but you have to focus on something in research, I guess. It can't be too broad. And then we'd go on to measure various well-being indices in a population of doctors. And the idea then would be that the results of this research would inform findings that we would undertake with some interventions, perhaps with the employer and with the postgraduate medical training bodies, including our own, the Royal College of Physicians of Ireland. So I'm not going to go into detail into the identification of the sources of stress, but we published this in an article in BMJ Open a couple of years ago. We used a Delphi technique to identify the sources of stress in both hospital trainee doctors and consultants. The consultants were particularly exercised about the lack of good strategic planning and anything other than quick fix decision making. Both groups felt undervalued in their role, though they expressed that somewhat differently. Both were concerned about the quality of patient care. And the trainees were concerned about the impact of work on their health and on their personal life in ways in which people of my generation would have been unable to articulate this. So I think we are getting to a stage where young people, both men and women, are much more interested and are unapologetic for wanting to have work-life balance. So to answer the second question then, we applied a number of standard instruments and other single-item questions to a cross-sectional population of hospital doctors. The aim was to assess psychological well-being in hospital doctors with a view to informing, as I've said, future interventions. It was funded by the Health Services Executive, which is the employer of all of the hospital doctors. And I suppose that reminds me, I should have said at the outset, I have no conflicts to declare, but I didn't insert a slide. That was an oversight. We engaged with all of the postgraduate training bodies, the College of Surgeons, College of Anaesthetists, Psychiatrists, and our own College of Physicians. And we used various standard instruments, which I'll mention in a moment. We looked at demographic details, measure of career satisfaction. We did look at lifestyle, and I'll give you just one slide on that, and of course we could probably do a whole session on that. We looked at personal well-being measures and workplace well-being measures. And the sample was randomized, and over 1,800 completed it, but many of them didn't actually meet the inclusion criteria. Pretty much half and half consultants and trainees, pretty much half and half male and female. But of course, as you would expect, the consultants much more likely to be male and the trainees much more likely to be female. And interestingly, in a country where we rely hugely on importing doctors from developing countries, and we're the country in Europe with the highest number of doctors from developing countries, and of course there's an ethical question there about how we are depleting doctors from those countries to fill our own gaps in our own very challenging system. 85% of the respondents to this study were of Irish nationality. But that's a bit deceptive because in fact we were just through the training bodies able to target those who were registered on training schemes or those who had achieved a consultant post, not those who were doing locum posts or who were working in service jobs, not on training schemes. So that doesn't for 1 minute suggest that all of our hospital doctors, or most of them, are of Irish nationality. That's not the case. Always interesting in the competitive environment in which we work to see, who are the most likely to respond. Now, anybody living in Ireland, any man or woman in the street, if you ask them who are most likely to be the most stressed out doctors or the busiest doctors, they'll almost certainly say the emergency, the doctors working in the emergency medicine, because we have a real crisis in our emergency departments. But in this group, you'll see the College of Ophthalmologists of Ireland, COI, were the least likely to respond at about 30%, but the busy, probably very stressed emergency doctors responded at 63%. I think I forgot to mention that the overall response rate was about 55% and a bit higher in consultants than in trainees. But here we have the emergency docs responding relatively enthusiastically. So what about the results? Well, these are published in an online publication if you just want to access it through the Royal College of Physicians, rcpi.ie. And we just published last year the crude analysis without going into the crude data rather than going into any analysis, because as you all know, it takes time to write these kind of papers up for publication. So this was the lifestyle data. As I've said, just one slide. A quarter of our doctors were inactive, and only 1 in 5 achieved exercise levels to a level that was health enhancing. So that's pretty worrying when we know that doctors are role models for their patients, both in how they live their lives and in the advice that they formally give to patients. And we know from the literature also that doctors who are more healthy in their lifestyle across these various variables are more likely to take the minute or so to have that conversation to motivate their patients to change their lifestyle. So that was a bit worrying. Anybody living in Australia, I think, will know enough about Ireland to know that we have a very unhealthy relationship with alcohol, and unfortunately that seems to affect our doctors also. 11% of our respondents across the board admitted to binging on a typical day when drinking alcohol. This, of course, was much higher with the junior trainees at about 19% and was lower at consultant level, but it was still about 6%, which is fairly high. Likewise for smoking, one would have thought that most doctors, well, indeed most doctors are non-smokers, but I was concerned to think that still 10% were admitted to smoking. Again, this was much more likely in the younger cohort than in the consultants. And I suppose the only reassuring thing about that is that only 2.5% admitted to actually smoking daily. There's a lot of talk about what doctors do and doctors don't do, and this was a headline in one of the tabloid newspapers when the RCPI publication got a bit of media attention about a year ago. Doctors don't do little, and indeed we know they don't. So we didn't really measure workload in any proper way because, of course, you know when doctors get a big, long questionnaire, they can be very reluctant to answer it. And the focus was on well-being. So we just asked the question, how many hours did you work over 2 consecutive weeks in the last month? So this is a mean figure for weekly working. And we excluded those who worked part-time because we thought that would falsely reduce the mean working hours. So as you can see here, we have in Ireland, we supposedly implement the European Working Time Directive, which requires people to work under 48 hours per week on average. So you can see the psychiatrists were the only doctors who came in barely just under the European Working Time Directive. Surgeons worked the longest hours at 69 hours per week. So that was a proxy for workload, but I acknowledge it's not a very good measure of workload as such. It was quite concerning that in response to the WHO-5, which is a very simple instrument to measure well-being, some of you may use it in your medical clinics to monitor patients' well-being over time, we found that only half of our doctors using this instrument achieved normal well-being, whatever that is. But to look more specifically at indices of personal mental well-being, we used the DAS-21 instrument, which has 7 questions looking at depression, depressive symptoms, 7 at anxiety, and 7 for stress. This is not a diagnostic tool, for example, like the Beck's Depression Inventory or something like that, but I kind of like the way it measured the sort of 3 areas. And it's unfortunately, although we chose it for this study, it's not an instrument that has been used widely in the medical profession as yet. But I still think it's a good tool, and it justified its use. What we came up with, that's the WHO-5 result of 50-odd% normal. Looking at those who scored with severe or extremely severe measures of depression, 7.1%. And if you add that to the mild to moderate, you can see it moves well up above 20%. But I leave you to do the sums there. For anxiety, again, looking at severe and extremely severe symptoms of anxiety, 6%. And for stress, that's personal stress, not specifically work-related stress, the figure was nearly 10%. And again, if you add in the mild to moderate, it's very much higher. So that's a concern for us. And the details of that we published in BMJ Open last summer. So those of you who are interested in a bit more detail can easily download that. As you know, it's an open journal and free to download. Moving on to some of the other things that we looked at in terms of work and life overlap, we asked a question that's been used, a simple single question that's been used by Shanafelt and others in the US, as to whether people felt they had enough time for their family or their personal lives. And only 4 in 5 doctors said that they did not have enough time for their family and personal life. As you can see there, 22.3% said that agreed with the statement that they did have enough time. If you look across from consultants, they were more likely to agree or strongly agree. And interestingly, our most junior trainees, the BSTs, the basic specialist trainees, were least likely to agree, with our higher specialist trainees somewhere in the middle. Looking at the term presenteeism and how many of us are in work when really probably we shouldn't be because we're sick or we're injured and we're carrying something that really doesn't allow us to focus fully on the job. And I acknowledge this is a very rudimentary way to measure presenteeism. It's a self-declared view, and it's just a single question. But again, it's been used in other studies on doctors and others. And as you can see, 4 out of 5 reported that they had been in work at a time when probably they shouldn't. And I'm sure much of this audience would be the same. We used an item called the Workability Score. Now, any occupational physicians in the audience will be very familiar with this term. It comes from Scandinavia, specifically from the Finnish Institute of Occupational Health. And it's really what you bring to work and how you can balance that with what the demands are. So how you would rate your current workability as rated towards your lifetime best is the single item question, although we didn't use the longer instrument. But this single item question has been used also in a Dutch study of doctors some years ago. If you come in at under 6 of a score, that suggests that your workability is insufficient. So the mean level of workability across our entire population was only a little bit above 6.5, with a standard deviation of 2. And when we looked at our respondents who actually met the criterion for poor workability, it was 29.2%. And that was across the board. There wasn't really any segregation between the grades. So the consultants were as likely to have poor workability on this score as the junior trainees and the senior trainees. That's much higher than from the Dutch study, I can assure you. Moving on then to the very specific workplace measures, the work stress, and I'll follow that with some slides on burnout. So I used the effort-reward imbalance instrument. We've talked before, you've heard reference to work demand and control, and there are measures to measure demand control, the demand control support model. But this is Segrist's model. It's a newer model of work stress. And I felt it was appropriate because it encompasses the concept of overcommitment, which I think is pretty common in doctors. So you come up with a score called the effort-reward ratio. And really, in an absolutely fantastic job, your ratio would be down near 0, but certainly 1 is acceptable, pretty much of a balance. Anything over 1 rather, is heading up into significant work stress. And our figure was 1.4. And as you can see, it's pretty much the same across consultants at 1.4, HSTs 1.5, and BSTs 1.4. And overcommitment would be considered pretty high on these figures as well, but I'm not going to discuss that in any detail. So these figures suggest very, very high levels of occupational stress in our population of hospital doctors. If we look at the specialties, you can see that the ophthalmologists had the highest figure, but I don't really buy that because their response rate was relatively low. But I do buy that, the emergency doctors. I think that's probably valid. And as I've said, if you ask the man or woman in the street in Dublin or in Ireland who are likely to be the doctors experiencing the most stress, they would say the emergency doctors, because it's constantly in the news. And you know, you may look at your own specialty here. Physicians, whom we didn't break down for this, 1.5, pretty high. Surgeons a bit lower. Moving on then to burnout, and everybody's interested in burnout, even though we're not really fully sure what we're measuring here. It's not like looking at depression or anxiety, which are very specific sort of clinical entities. But we measured it because it allowed us to compare with literature elsewhere. And by our measure, 1 in 3 of our doctors suffers burnout. As you can see, once again, looking consultants a little less likely, about a quarter of consultants, and up near 2 out of 5 of our HSTs, our higher specialist trainees, and our BSTs. And looking across the specialties, again, you can see emergency medicine, 44%. And the lowest were the pathologists at 21%. Sorry, again, leave that there. You might wish to look at the gradation across there. And then we did a further analysis on burnout and what kind of factors seemed to correlate with burnout. And of course, we can't attribute any causation here because this is a cross-sectional survey. And I'm hoping to use this to maybe advocate or get funding for a longitudinal survey on our hospital doctors, but that conversation is only beginning now with these results coming out. We found that, as you can see, there are various levels of significance of association with the various variables, but I suppose I draw your attention to sorry again, I'm having a little difficulty with pushing the wrong buttons here. You can see a highly significant association with an odds ratio of 1.57 with the work stress. That's as measured by the effort-reward imbalance. You can see likewise with overcommitment, with the workability score that we used, and perhaps also significant association with other variables, including career choice, presenteeism, and so on. And also the figures in the emergency docs were highly significantly higher than in the others. That did reach statistical significance, the slide I showed you earlier, comparing the specialties. Younger age, that's very consistent with the literature. There was a systematic review published on burnout a couple of years ago, undertaken by a bunch of very enthusiastic British medical students, if you don't mind. And they found that burnout was more common it was much more associated with younger age, so junior doctors, and with females. But interestingly, we didn't find that in our population, and I really don't know why. We need to think about this a little bit more. So younger age, yes, male sex in our population, and higher symptoms of stress. That was the personal stress as measured with the DAS instrument, the Depression Anxiety Stress Score. Interesting as well, no effect on working hours. And people say this, you know, it's hours worked, and we came along in Europe and we introduced the European Working Time Directive, and we said that's going to fix everything. But of course, people are very bad at looking at what are the unintended consequences of various initiatives. And the unintended consequence of the introduction of the European Working Time, at least in Ireland, was that managers just said, well, we've got to make this work. We'll use the same number of doctors. We'll just squeeze everything in, and they'll have to work much harder. So it has caused, as we've reported in our earlier paper that I mentioned on the Delphi study, it has reported significant fracturing of teams. People no longer know what team they belong to. They're covering nights for a week when they're not working with their own team and so on. So we've had all of these unintended consequences of trying to get the hours down. And I often say, doctors don't really mind working long hours, actually. Most doctors expect to work hard and work long hours, maybe not the kind of mad hours we worked when I was a junior, but they don't mind working hours if their work is fulfilling and supported and rewarded. So don't just try and fix the hours without doing anything else. And so this was interesting, that there was no effect on the work hours or indeed on the years of practice. And I suppose after all of that bad news, it's important to look and see, was there anything redeeming, any redeeming features in this? Well, we did find that 7 out of 10 of the doctors still have a strong desire to practice, despite all of those negative measures. So that's something we can, I suppose, work with and hope to maybe change how we support doctors in their work. I do want to mention a word about stigma, because this is a huge barrier to dealing with mental health and burnout issues in doctors. I wonder, is it perhaps more of a barrier in older doctors than in younger doctors? There's some suggestion in the literature that younger doctors are a bit more open, but I don't think we can be complacent about that, because certainly as a profession, we're very guarded about mental health issues. And I suppose that's why I would really salute my colleagues from 5 or 6 years ago, when this whole interest in this area began in Ireland. The colleagues who came out very bravely, some of them very senior clinicians in hospitals, well known, who spoke about their own experience. And that's the kind of thing that does most, I think, to challenge stigma. We are much more stigmatizing about mental health as doctors, I think, than the general public. The general public is pretty self-stigmatizing in relation to mental health, but we are more likely to self-stigmatize. And 2/3 of our respondents reported that if they were experiencing mental health problems, they wouldn't want people to know. So again, you can see that here. 2/3 agreed or strongly agreed with that statement. And again, consultants a little less likely to agree with that statement. I suppose when you've reached the top, you're maybe feeling a little bit more secure, a little bit less worried about how it's going to impact on your career. This compared to an Irish population survey that asked the very same question, albeit about 7 years earlier, because there hadn't been a more recent one, because there was very little funding for these kind of national population surveys during the post-Celtic boom-bust in Ireland. So, it's not exactly comparable perhaps, but the population survey, 52% in general said yes to that question. But if you controlled for socioeconomic group, the figure was a little bit higher, 55%. So isn't it ironic, and I challenge all of you, isn't it ironic that we who know more than anyone else, even if we're physicians or surgeons and not psychiatrists, we know lots about mental ill health. We know how treatable common mental disorders are, and we even know how treatable some of the more significant and more serious mental health disorders are with the right treatment. And still, we have this very self-stigmatizing attitude when we become ill ourselves. And again, you can look at the different specialties here. The psychiatrists happily were the least self-stigmatizing. So they're doing something right, but they're still pretty high, aren't they? The ophthalmologists, again, with the caveat about the response rate, were the most likely to stigmatize. It's interesting, too, that those specialties whom I think probably we would consider don't have quite the same level of enduring contact with patients. Although anaesthetists working in pain clinics would, but generally, otherwise they wouldn't. And anaesthetics and pathology had high levels of still self-stigmatizing thought. I want to mention this as well. This is the work of Niamh Humphreys, my colleague in the College of Physicians. These were some of the quotes taken from our survey, because we allowed a full page of free text, and over half of the respondents took the trouble to reply and to offer thoughts on various aspects of mental health in doctors. So again, I won't read through those, but they're probably all available to you in your packs. Just to finish up then, it's always worth looking at data in a different way. So we decided to do a cluster analysis. I talked to my friendly statistician and said, how would you advise we look at this? So we did a cluster analysis of all the data, and we threw up 3 clusters for consultants and 3 for trainees. So we I'm coining them those with a positive environment at work and those with a negative environment at work, and the intermediate were the control group, and likewise for the trainees. And then I asked my friendly cartoonist, who was a young graduate of the same medical school as my friend Peter, a guy called Owen Kelleher, who was an intern in our hospital and who on the side does a bit of cartooning. He's now training to be an anaesthetist, and he used the data to inform the next 4 pictures. So they're very true. There's no, apart from one little bit of poetic license, which I'll mention in a moment, they're all true to the data. So this is the consultant experiencing a negative environment at work. She's depicted as female, but actually the gender didn't really matter. You can see she's relatively young, she's stressed, she's overcommitted, and she has a poor work-life balance, and she's actually burnt out. You can see that she's pretty inactive with that little couch up in the corner there. This is her consultant colleague who is experiencing a positive environment at work. He's depicted as male, but he doesn't have to be. The data didn't require him to be male. He is a bit older, however, as you can see. He enjoys practicing, he has a sense of accomplishment in his work, he's enjoying his free time, and he's not too stressed. Take a note of the effort-reward balance, and I want you to particularly remember the number of euro signs on the scales there. And we'll move on to the junior colleagues. This is the trainee with a negative experience at work. Again, gender doesn't matter here, could have been either. He's doing long hours, he no longer wants to practice, his mood is low, he hasn't got time for friends, or he's stressed and he's burnt out. And he too has got his couch, thoughts of his couch in the corner. The one bit of poetic license here is that he's developing a little paunch. And that's the cartoonist's license, because we didn't actually measure BMI or ask about weight. But it figures. And here is the trainee with a positive experience of work, and again, gender doesn't matter. But I'd ask you just to check out her effort-reward balance. And there's just the one euro sign, which means that her effort is measured as less also. So the senior consultant is bringing more effort according to the effort-reward imbalance questionnaire, and more reward than the junior trainee. And again, that probably tells us something about how this new generation wants to work, and we must take account of that in planning for the future. I mentioned my colleague Niamh Humphreys. She's a reader in health system research in the College of Physicians. She won an Emerging Investigator Award recently for a project looking at doctor retention in Ireland, which is a big problem for us. She's coming to Australia to do the first phase of that study, and she's looking for Irish-trained doctors in Australia. And she'll be here in July and August, and I promised her I'd mention it at my talk. These are just some of the acknowledgements of people who've helped me along the way, and some of the resources available on the College of Physicians website that we've put together over the last 4 or 5 years. And thank you for your attention.
Well, ladies and gentlemen, it's a responsibility of us as physicians to be caring for our colleagues and our trainees, and I'm delighted that Blánaid was able to share that information and research with us and to stimulate us to move in a similar direction, and I'm delighted that our college is actively working in this area, and I'm delighted that we can collaborate together in this very important work and responsibility that we all have. So I look forward to disrupting our own thinking and our own actions so that we care better for our trainees and our colleagues, and I'm delighted that we're working in that direction already.